Okay, and we are live.
Good afternoon, everybody, and welcome to the California Immunization Coalition Education Hour. I'm Mariah Bianchi, the Director of Quality for UCSF Health and the co-chair of the California Immunization Coalition Education Committee. I'll be your moderator for today's call. The California Immunization Coalition hosts education hours throughout the year on immunization-related topics to help our colleagues stay up to date on important news and information. Our program for today is titled Partnering with Health Plans to Raise Immunization Rates. We are pleased to have several experts today provide us with an overview of the measures that health plans must work toward and some examples of several successful California partnerships that use collaborations to improve rates in adolescents, 2-year-olds, back-to-school programs, pregnant women, and more. Our speakers today have extensive experience in immunization-related work. In an interest of time, please see the webinar registration site for detailed bios of our speakers today, as well as an overview of their presentations. Briefly, I would like to mention who they are and what they will be discussing. We have Dr. Sarah Royce, who is the Chief of the California Department of Public Health Immunization Branch, and will be speaking on public health and Medi-Cal collaborations to increase immunizations. Sally Nagin is a nurse and facility site reviewer with Anthem Blue Cross in the Central Valley. She will be speaking on partnerships to increase immunization rates among 2-year-olds in the California Central Valley. Hillary Gillette Walsh is a clinical decision quality manager at the Central California Alliance for Health. She will be presenting on how Central California Alliance has tackled low adolescent HPV immunization rates. We also have Amy Pine. She's the Immunization Section Director at the Alameda County Public Health Department, and she will be presenting on a partnership that they had to increase vaccinations for pregnant women in order to prevent infant pertussis. And finally, we have Meg Dorsey. She is a nurse and the immunization coordinator for Placer County Health and the Human Service Agency. She will be discussing how the County of Placer leveraged health plan relationships to expand access to back-to-school immunizations. Before we get started, I would like to go over a couple of the objectives for today, and we are hoping that after this education hour, you all will be able to do these 3 things, and really focusing on how we can influence immunization coverage levels, describing the benefits of partnering with health plans to improve immunization rates, and also to apply lessons learned from some successful immunization partnerships that we will hear about today. Before we get started here, I would like to go over a few logistical housekeeping items. The education hour is hosted on the Global Meet platform. We have muted all participants due to the sheer size. You can listen through your computer, your device's audio channel, as well as on the phone line. Throughout the presentation, you may ask questions in 2 different ways. You may see a chat box in the lower portion of your screen with green. If you are having any technical issues and you cannot hear, please join the phone lines. There's phone numbers there. You might be able to see an example. But if you are having any technical issues, please go ahead and chat an item there. In terms of questions for presenters, at the lower portion of your screen, you should see a little plus sign and a question mark, and it is under the Manage Q&A section. If you have a question at any time during any of the presentations, please click on that little plus sign with the question mark, add in your email address, type in your question, and hit Submit Question. We will compile a list of all the questions that come up, and we will save the last 10 minutes of our webinar today to address questions. For those questions that we are not able to address verbally, we will answer them, and those will be available afterwards. Next, please. A couple frequently asked questions. Everyone will have a copy of today's presentation on the immunization on the CIC website, and you will also be able to have a copy of the recording there as well. So with that, I'm very excited to turn it over to Dr. Sarah Royce, who will be our first presenter today.
Good afternoon. Next, please. So next slide, why should public health and Medi-Cal work together? First of all, Medi-Cal's big. It covers 1 in 3 Californians, 40% of all the kids in our state, and more than half of the births. It's an opportunity. When we collaborate, we have the opportunity to address some disparities and improve rates. Here's some data from Medi-Cal Managed Care members in 2018. 71% of 2-year-olds were up to date on their immunizations, 42% of 13-year-olds, so we've got room for improvement clearly. Also, of the 13.2 million Medi-Cal members, 82% are enrolled in managed care plans. So we have the opportunity to leverage an organized delivery system to get data and share data and to align our quality improvement efforts. Next. So keeping people fully immunized on time requires access to healthcare, getting in the system, and then once they're in the system, a healthcare system that delivers the right services at the right time. Here's some examples of Medi-Cal policies that promote access. There's transportation assistance. Immunizations are a medical and a pharmacy benefit for adults, including pregnant women. Preventive services are supposed to be given within 2 weeks of request for managed care members. You can see much more detail about access and delivery of the right services in the 2 sets of FAQs at the link here that were also sent out to you this morning. Next. So by contract from the state Medi-Cal agency, managed care plans are required to ensure documentation of each member's need for advisory committee for immunization practice recommended immunizations as part of all regular health visits. They're also supposed to ensure timely provision of recommended immunizations. So strong language in the contracts between the state agency for Medi-Cal and the plans, saying the plans must ensure adults are fully immunized and all children receive necessary immunizations at the time of any healthcare visits. These contracts also require the plans to assure that immunizations are reported to CARE, our immunization information systems, and that patient declinations are documented. So this is really good, strong language, but how well does it really work? What's it like in practice? Next. So to assess and assure quality of care, Medi-Cal Managed Care Plans have to report on their performance. They have to report the proportion of children up to date at the time of their 2nd birthday. That includes 10 vaccines, including this year 2 doses of flu vaccine. And it's really exciting that finally this measure aligns with the quality improvement work we do in the Vaccines for Children program for my branch. It aligns with the quality measure in federally qualified health centers that those clinics report to HRSA. It aligns with National Community and Quality Assurance Health Plan accreditation and the commercial plans HMO incentive. So finally we have good alignment on the 2-year-old measure. The other measure that immunization measures that plans have to report is the proportion of 13-year-olds at the time of their birthday, how many are up to date. So Medi-Cal Managed Care Plans must meet a minimum performance benchmark, and if they're below, they have to do quality improvement work, they get sanctioned, and sometimes corrective actions imposed. And these data are published, so anyone, the public, providers, public health, can see how well plans are doing in each of these 2 Medi-Cal Managed Care immunization performance measures. And finally, also to assure and assess quality of care, managed care plans are required to follow up on potential quality of care issues brought to their attention. For example, an infant pertussis case born to one of their members who wasn't vaccinated is a potential quality of care issue in that mother's prenatal care. Next. There is also, starting in July, a new incentive program called the Value-Based Payment Program, where Medi-Cal Managed Care Plans are paying $25 to managed care providers for Tdap administered to each pregnant woman in Medi-Cal Managed Care, each flu immunization given to members 19 years and older, and the last dose in any multi-dose series to a child on or before their 2nd birthday. So the provider can get up to $175 if you add up all the vaccines. Contact your managed care plan for more information about how they're implementing this program. Next. So in summary, working together to protect Californians, we've got lots of areas for collaboration. Public health can look up the managed care plans operating in the Medi-Cal Managed Care Plans operating in your jurisdiction to see, okay, what is the immunization rate for the 2 and 13-year-olds in their members in your county or in your jurisdiction. You can review the memorandum of understanding that's required between health departments and managed care plans, and it should contain sections on billing and reporting and coordination of services. And then public health and managed care can be meeting together to identify ways where the 2-year-old and 13-year-old immunization rates are lagging, how can they improve. They can also work together to ask the managed care plan to run the new prenatal Tdap and flu immunization measure. I have a link to it on the reference slides to see how this measure, how the plan is performing in terms of getting pregnant women immunized. And the results of these performance measures can help both the local health department and the managed care plan focus on particular providers to improve their immunization levels. You can figure out which ones are doing great, and some of those experiences can be replicated, like you'll hear in the subsequent presentations today. And I think another way to partner is to increase the use of the California Immunization Registry or CARE to implement these new value-based payment program incentives, and to for health departments to come forward with state-funded prenatal Tdap doses, starter doses, that we at the state are making available for free to local health departments to give to managed care or other providers who are seeing Medi-Cal patients. And finally, working together, it can entail helping the plans hold their provider network accountable. We know that even though the policies look strong and good on paper, there's always access problems. And the more public health can understand what's supposed to happen, then local health departments, when they hear problems from Medi-Cal clients, they can help navigate, starting by calling member services or using their MOU meetings to address them. And this action of being responsive to concerns about access is part of the requirements from my department to local health plans in their immunization assistance awards. And if they can't be resolved, to bring issues to the managed care plan. The last two slides are for your reference only to show you which you can click on the link, Health Plan Directory, to figure out which your plans are if you don't know yet. And then the very last slide has a number of links to more information. Thank you very much.
Wonderful. Thank you so much, Dr. Royce. I would like to turn it over to Sally Nagin, who will be speaking about partnerships to improve immunization rates in the California Central Valley.
Great, thank you. This is Sally. And next, please. Anthem was very fortunate to have a long friendship, working relationship with staff in the Central Valley through the Central Valley Immunization Coalition and Vaccines for Children. And so we've set up a relationship, a partnership to work on a pilot within the county to raise the immunization rates on 2-year-olds. Next. When this partnership started, we were still doing Combo 3 for the health plan for HEDIS. But because of the fact that Vaccines for Children and all of the other programs through ACIP recommendations were actually using Combo 10, we did, even though the project started in late 2017, we did go ahead and use Combo 10 as our baseline. Next. The program worked on, and the process was working on using the AFIX project and the model to improve the immunization rates and the practices at the immunization provider level. And that includes coaching, quality, the opportunities versus the problems, and improvement efforts focusing on the systems, not the people, and then including all of the office staff within the project. We were able to go ahead and work on an agreement and a process where we actually had lunch scheduled. The managed care plan was able to pay for the lunch. Karen Turner, who was working with the VFC part of the project, did the AFIX, went through the questions, discussed their process, their problems, what they were doing, what they weren't doing, and we were given a great picture of all of the opportunities. And then the managed care plan went back in and we asked for the medical records for all of the kids that were going to be that had turned 2 during 2017. We obtained medical records on 100% of those 2-year-olds, and the managed care plan looked up and copied all the immunization rates for comparison with CARE, which we also looked up. We were able to then identify where some of the issues might be. It gave us a really good overall of the entire project. And then we were able to talk with them about opportunities to improve. We did the same project at the end of 2018 of grabbing all those 2-year-olds, going through all those records to determine if there had been an improvement, celebrate with some of them, and then go on to look at opportunities that they might have on site, as well as just looking at the records and seeing what was documented there. Next. We determined that we were going to try and hold it down. We had 11 sites total. 7 of them were private sites, which had either multiple providers or individual pediatric providers. 3 were FQHCs, and 1 was an RHC. Next. Of those we looked at, and I will say that I looked at over 878 immunization records. There were about 22,000 total number of immunizations needed for all of these records. And they were missing about, initially the 2,393 were missing and or out of time frame. We did not look at whether that in time frame included if it was a day early or a day late within that time frame, but just that they were before the 2-year-old to make sure that they were getting it either after that, if it was after the birthday, we eliminated that as a possibility. What we found is that we also looked at what was missing and what was not missing based on the vaccines, and that gave us a very interesting picture. Next. It became very apparent with, for one provider as an example, that his issue was Hep B. This provider, during the AFIX visit that we had with lunch, indicated that he would not enter in any historical data. He did not want to, and his word was pollute his medical records with anything that was not correct and not his doing, that he didn't have the ability to control the situation. But that included the historical data on his hepatitis B, so it indicated at every time that that hepatitis B was not given at the hospital birth. So we had a long discussion with him, and Karen was able to show him the importance of having that to give the whole picture that he's had, that the child has had all 3 of those Hep B. He was one of the physicians we were able to celebrate with the following year because his immunization rate just went through the roof once he entered that, because he was meticulous and he was able to follow with all of those. So what did we learn next during this whole entire study and process was that we had some sites that were very different, providers were very different, their practices, the entire process was different at every site. It made a big difference to actually look at every medical record for every site and see that difference and be able to analyze it and go back and have a follow-up visit with them and be able to impact those immunizations rates, which we did. Next. We also looked at the best practices and what we were able to see with those best practices, that we really needed to look at their dashboards, flags on some of their EMR systems. The morning huddles were talked about, that the front staff really needed to know what to do about immunizations and how to check if they were up to date as they were either scheduling in or scheduling out. And cell phone messaging, text messaging was making a big impact, and that there was one site that was making their recall 30 minutes after a missed appointment. We found that there were opportunities and that the challenges were there, and we really looked and were able to determine how that partnership with CARE was able to support, because they have a great relationship with each of the sites. And we were able to use some of having staff and having the ability to support with the lunches and some of the gifts and the parties that we followed up with. We did find that it was difficult to coordinate with a lot of schedules. Finding time with the physicians was difficult, but having VFC staff on made it very important. So it was great, and it worked really well to improve our rates within the Valley. Thank you very much.
Wonderful. Thank you so much, Ms. Nagin. I'd like to now turn it over to Hillary Gillette Walsh, and she will be presenting on how Central California Alliance for Health tackled low adolescent immunization rates using story, data, and skills.
Thank you. Well, good afternoon. The Alliance is a Medi-Cal health plan. I work in the quality department. Part of my job is to support primary care clinics in applying best practices. First, a little bit more about the Alliance. As you can see on the screen, excuse me, the Alliance covers 3 counties. And essentially, if you're a Medi-Cal member and you're living in one of our counties, you're probably our member. As Dr. Royce covered this briefly, so we're a county-operated health system. So what's important about this is the impact on community health and how tied in the Medi-Cal plans are to how we can improve the local health. So we cover approximately 1/3 of the population in our region. So our efforts to improve health of our members impacts the overall health of the community and vice versa. So the story begins in 2016. Our plan had failed to meet the minimum rate for adolescent immunizations in Merced County. And when I talk about adolescent immunizations here, I'm referring to the Tdap, HPV, meningococcal vaccines given before the 13th birthday. All right. So in the spring of 2017, we were still struggling. We started our quality improvement work, as Dr. Royce had described, and so we were still struggling to improve the rates. Our strategy for improving adolescent immunization rates was really focused upon provider training, provider education. So while the adolescent measure included both Tdap and meningococcal vaccines, those vaccines enjoyed a relatively high rate. To truly improve our performance, we had to bring up HPV vaccination rates. As the title of the presentation indicated, we ended up coming at the adolescent vaccinations through the tactics of story, data, and skills. This approach first came together when we presented at a coalition meeting alongside a pediatric infectious disease physician. The Alliance brought the story and the data to the table, and pediatrician addressed skills. In this case, how to speak with parents about HPV vaccine. This was a true partnership between local public health, the plan, clinics, and other essential partners. So this is a short story, but the story starts like this. This is my firstborn daughter. Picture was taken at spring break, Joshua Tree National Park. Little did she know that as she stood there in the hot desert sun that her mother was plotting to vaccinate her in just over a week. Unfortunately, that routine well-child visit didn't go entirely as expected. I ended up having to convince the medical assistant that my daughter should be vaccinated for all 3 vaccines at that visit, not just the Tdap that she was meekly offering. In the end, my daughter was vaccinated, but fortunately or unfortunately, she ended up as a poster child for the Same Day, Same Way campaign. So after sharing that story next, typically pivot and share with the community what I know about Medi-Cal members living in their community. This is updated data, for example. This is showing data through October of this year. HPV vaccinations by gender. And then down on the right side, how HPV vaccinations match up against Tdap and meningococcal vaccines. Beyond my personal experience in working hard to get my daughter vaccinated, I really take umbrage that HPV has been around for so long and yet continues to lag behind the meningococcal vaccine, also not required for school entry. I think contrasting the ease and success of the Tdap and meningococcal vaccines against HPV vaccines was also really surprising to our audiences. And then finally, I would map data by zip code for where our members live and their up-to-date rates. As you can see in the slide, the rates of children being up-to-date for HPV vaccination range somewhere between 27.5%, 54%. Next. As I mentioned earlier, it started with one county and was really well received. We took the presentation on the road and to our other two counties with support from key partners. In addition to traditional coalition meetings, our team produced webinars and tip sheets to support our clinics in the network. The first webinar was built off the Immunization Action Coalition tip sheet you see on the screen and the CDC standards for immunizations. We initiated partnerships around immunizations where none existed. And this meant building these systems in 2 out of 3 counties we cover. In all cases, we invested staff time and resources to get these conversations going. So next, this is an overview of that journey. As you remember, I mentioned we started in 2016. We had fallen below the minimum rate. So you see the thick blue line on the left side of the screen. That's the last quarter of 2016. In 2017, the measure was updated to include HPV, and this county fell all the way down to 20%. Because the measure had changed, we weren't required to hit a certain target. In 2018, you can see the target came back online. We were doing fairly well. That work we had done over 2016 and 2017 really had paid off. We were performing at the 75th percentile. Unfortunately, or fortunately, as we improved, everyone across the country was improving at the same time. So the benchmarks increased for 2019. It's taken all year, and it took until October of this year to kind of crawl above that minimum benchmark for Merced County. There isn't time to really cover everything that we've done in Merced County or any of the counties to improve vaccination rates. No single intervention will raise immunization rates. I believe that stories have a place in engaging your audience. In this case, it was my true story. Describing what we know using available data further deepens the understanding of our current challenges. Finally, when your audience is primed, you can start building on their existing skill set. There's so much to learn beyond vaccine administration. For example, the nuances of parent communication and navigating the catch-up schedule. Finally, I've learned there's no such thing as too many partners. It takes a wide variety of partners and interventions to make progress, and you must be committed to a long journey. Thank you.
Thank you so much. That was wonderful. I'd like to now turn it over to Amy Pine, and she is going to be sharing with us their experience as they partnered with infant pertussis prevention by vaccinating pregnant women with the Tdap vaccine.
Thank you, Mariah. Excuse me. Yeah, I think it's just fine to just jump to the next slide, please, and I'll just jump in talking about pertussis. It is a serious disease, and it is most dangerous for infants. They are particularly vulnerable until they're old enough to begin the vaccination series at about age 2 months. It's a cyclical disease with incidence peaking every 3 to 5 years, and California is currently due for another epidemic. We had epidemics in 2010 and in 2014. In 2010, we had 10 infant deaths. In 2014, we had over 11,000 cases and 2 infant deaths. We also had an infant death this year in 2019 in Southern California. The infant cases have also been overrepresented in the Medi-Cal population, and a 2016 maternal and infant health assessment survey showed lower Tdap protection rates among pregnant women in Medi-Cal as compared to pregnant women with private insurance coverage. And as you can see from this graph, Alameda County also experienced epidemic levels of pertussis in 2010 and 2014. And in 2018, we are approaching epidemic levels with over 300 cases, 5 of which were in infants younger than age 4 months. We're really frightened of infant pertussis, and we don't want it occurring in Alameda County, so it made sense to investigate partnering with a Medi-Cal Managed Care provider to see if there was anything that we could do. So next, please. We've been fortunate enough to have partnered with the Alameda Alliance for Health. I think, do you mind just going? Yeah, there you go. We've been fortunate enough to have partnered with the Alameda Alliance for Health, and the Alliance is our biggest Medi-Cal managed care provider. They've been in business since 1996, and their network includes over 4,000 providers, 15 hospitals, 29 community health centers, and 200 pharmacies. And together we came up with this overarching goal of eliminating infant pertussis cases in Alameda County by vaccinating pregnant women between 27 and 36 weeks gestation. Partnering with the Alliance allows us to focus on pregnant women in Medi-Cal. So now we can go to the next slide and get into more details. The project started with me making a cold call and asking to talk to the person in charge of quality improvement, and it took a while for them to know what the heck I was talking about, but finally I got to the right person, and then I was put in touch with someone from clinical quality, and then I sent them a written pitch, and from that we had more discussions and talked about our shared goals of pertussis prevention and reduced healthcare costs and the individual strengths from our organizations that we could both bring to the table. We identified individuals within our organizations who could best assist, and then talked about methodology and data runs. So the Alliance has been able to look at claims and encounter data to examine Tdap immunization rates, and this data has made all the difference in the world. The denominator for this project has been the number of deliveries per provider, and the numerator has been the number of members who received Tdap vaccine, also from the claims and encounter data. They also look at CARE to verify, CARE being the California Immunization Registry, to verify. Kaiser members were excluded, as well as any deliveries before 27 weeks gestation. And the results were that both high and low performing providers were identified. High would be Tdap vaccination rates for pregnant women at 90% or higher, and low performing was identified as 80% Tdap vaccination rates or lower. And from all of this data, we identified 19 sites with 30. We decided to focus on sites that had 30 or more deliveries per year and a Tdap vaccination completion rate of 80% or lower. So it's fine to go to the next slide. We've been working with these 19 sites this year, and the project is ongoing and continuing into 2020 as well. But the very first thing that we did when we identified the sites was we started with an interview at the highest performing site, which was the San Antonio Clinic of La Clínica de la Raza. And then from that, we created a best practices handout that we've taken to all subsequent sites and also posted on our website. We've conducted in-person visits with the prenatal teams at these 19 sites, where we talk about their Tdap workflow, their electronic health record system, how they communicate about Tdap vaccine and any barriers. And we share data from the Alliance, which has been really wonderful because it shows potential missed opportunities for vaccination. And we offer technical assistance, educational presentations, and outreach materials, whatever might be best needed for that practice. And we try to follow up on all action items that come about as a result of the in-person meetings. Fine to go to the next, please. In terms of what we've seen and learned, the biggest challenge has actually been figuring out how to take women out of the denominator who were never seen by their primary care provider. We've also learned that it's been a challenge to vaccinate women who are involved in the highest risk pregnancies. It seems like a bread and butter item such as a Tdap vaccine gets overlooked in all the meetings and case conferences that might be happening about their high risk pregnancy. But a solution has been to add Tdap vaccine as a standing item on the high risk pregnancy meeting agendas. Patient refusals have been identified as an issue, as well as an absence of vaccine champions at some of the sites. The sites usually have pediatric vaccine champions, but not so much for adults. Sometimes care has been transferred to another site before 27 weeks, and it's challenging to ensure vaccination at that point. There's also a 3-month claims lag, so the data is never real time. It's been a challenge to identify a reliable marker for pregnancy early on to proactively remind people that they need a Tdap vaccine. And not all of the sites necessarily interface with care, and it's also been challenging to get some reports out of care. But on the bright side, we've had successes with things like talking about the presumptive approach to communicating, saying things like having the clinician say something like, today we're going to protect you and your baby from pertussis by giving you the Tdap vaccine, instead of asking, hey, do you want to get the Tdap vaccine today? Some sites have employed the use of a declination form. They've been excited about that. Sites have gotten savvy about prompts in their electronic health record systems and dashboards. And we've learned a lot about how some sites have really invested in empowering their medical assistants to check for missed opportunities. We've also gotten a lot of requests for posters and health education materials. And of course, we're just always trying to refine the data overall. Next. And the results have been good. This project is ongoing, but over the last 12 months, our immunization coverage rates for pregnant women have increased by an average of 8%. It's also led to really productive conversations and relationships with additional providers. And just working with the Alliance in general has been so wonderful. It's an active two-way communication where we have regular check-ins and shared drives, and it's really made a huge difference. And I just have one last slide, which ends with kind of a cheesy quote, but it's really true. Like, alone, together, we can do so much more, I think, than we've been able to accomplish as individual organizations. And that is all. Thank you.
I love that quote. Thank you for ending with that, Amy. I'd like to now turn it over to Meg Dorsey, and she is going to be presenting how they leveraged health plan relationships and expanding access to back-to-school immunizations. Meg.
Thank you so much, Mariah. The goal, you can go to the first slide, please. The goal of this project was to increase access to back-to-school immunizations for those students who were Medi-Cal insured and established with one of our safety net providers here in Placer County, thereby preserving the very limited immunization delivery service that Placer County is able to provide for the truly uninsured and non-established patients. Placer County is not alone. Just like all the counties out there, we scramble to meet the demand for back-to-school immunizations in the July, August, and September timeframe. I have noticed, and anecdotally, I don't have data on this, but the demand has been increasing for uninsured families here. This year, we had to expand to 5 back-to-school clinics. Last year, we had 2. The reasons for uninsured families needing vaccinations include folks that are new to the country. I'm seeing an increased number of families coming in through INS. Families that are new to the state of California and establishing themselves with Medi-Cal. Additionally, I'm sure we're all aware that Medi-Cal is not portable within California. So even if you move within a county, there's still a process which includes establishing an address, applying for Medi-Cal, waiting for the process to take place, and then, of course, Medi-Cal benefits are only activated on the first of each month. So this can easily result in a delay of several months for a family new to Placer County having access to Medi-Cal. Also, I'm sure everyone will be shocked to hear that insured established patients don't plan ahead to make appointments in the back-to-school time frame. So we were noticing that we were also having families show up at our clinics that were showing up for convenience purposes, having been told that their provider could not see them in a timely fashion. So again, the goal was to reduce the traffic at Placer County clinics and try to get folks to go back to their established medical homes. Next slide. So background, Placer County has 3 safety net clinics, and this is not a chain of three clinics. We have 3 clinics that see kids here in Placer County, and we are very underserved. And these 3 clinics have historically been unwilling to immunize non-established patients at back-to-school time. And the reasons for this include a perception of liability risk for unestablished patients. Also, they are very concerned about seeing a patient one time for shots and having that data adversely affect their overall HEDIS and UDS measures if they don't see that patient again for follow-up care. The safety net clinics also had no process for providing immunizations only in advance of a new patient well check. So even if a family was seeking to become established but couldn't get an appointment for several weeks, the clinic was not set up to just vaccinate that child in advance of the well check, which might be several weeks ahead. So here's a description of our activity. First of all, I just want to mention that our health officer, Dr. Rob Oldham, who has since unfortunately left Placer County, was very invested in working shoulder to shoulder with me on this project. Together, we met with the medical directors of our 3 Safety Net clinics and outlined the problem and got an agreement from them all to work on establishing walk-in shot service for their established patients. The clinics were informed that any of their patients presenting at our Placer County back-to-school clinics would be denied service and referred back to their medical home. Once we got the agreement from the medical directors of these clinics, the immunization coordinator, that would be me, met with office managers and lead nurses to discuss logistics and a process for setting up back-to-school shot service. So whenever you want to make a change, and especially if that involves asking people to do more work, it's always helpful to have some leverage. And in this case, we utilize the MOU, or the Memorandum of Understanding that Placer County has with one of its safety net clinics to provide safety net service for Placer County. We leverage the obligations in that MOU. Additionally, as Dr. Royce mentioned early on in the program, Medi-Cal Managed Care requires providers to offer or to provide requested preventative services within 10 days of that request. Clinics were unaware of this. This was a big aha moment for them, and it was a very effective point of leverage. It's also helpful to include the provider relations folks from your managed care plans to be involved in both the conversations and to assist in carrying the messages to your targeted clinics that you're working with. In this case, I worked with a variety of folks from the plans, and I'll mention that a little bit more in my last slide. So some of the obstacles I came up against were, sorry, we can't do this. There's no billing code for shots-only nurse visits. Well, that's true, and it's a very big challenge, but it's only really relevant in a fee-for-service model. Additionally, there were legitimate staffing and space challenges, but surprisingly, with a little bit of effort and creative problem solving, all 3 of the clinics I worked with were able to set up, except for one. We had problems with one, but they were able to solve these problems and move ahead towards meeting the goal. Next slide, please. So the results, they were mixed, but I would like to mention that return on investment, this did not require a lot of time or effort on our part, and I think that the results that we got, the return on investment was actually very high. So again, of the 3 clinics we did an intervention with, one clinic continues to this day to provide walk-in shot service for their own established patients in the afternoon, Monday through Friday, year-round. So this is a huge leap forward, and you can imagine that this particular clinic, this will have a huge impact on their immunization up-to-date rates for both 2-year-olds and for their school kids. One clinic was able to hold 2 distinct back-to-school clinics for their own established patients in the August timeframe. They were both very successful, and I believe that those clinics will continue to do so next year, and I'm hoping that we can even expand on that effort. One clinic attempted to hold clinics, but at the last minute was unable to do so because of a loss in staff. So that was definitely a problem. Next slide, please. So the lessons learned. I would say that having your health officer engage along with you with the medical directors is very effective. Sometimes starting at the bottom and working up is effective. In this case, for anyone who wants to try to replicate this project, I would definitely recommend starting at the top. Additionally, sharing success of one clinic can motivate others. I think it's always a good idea to say, to share with your clinic that's maybe bumping along a little bit more slowly that another clinic has solved this problem in this way and they're moving along effectively. Nobody wants to get left behind. Ensure that the safety net clinics understand their obligations with their MOUs with respect to both county services and with respect to the Medi-Cal Managed Care Plans in that county. Also engage with provider relations to help you, as I mentioned earlier, to carry the message and reinforce any plans of action with the providers you're working with. I do want to mention that in Placer County, we have Anthem Blue Cross and California Health and Wellness, and they're different counties. Different counties have all different plans and all different iterations of combinations. And each plan has different people that work in different ways. You may find yourself working with provider relations. These are folks that largely work on contract issues with providers. There are also quality improvement folks that you may find yourself working with, or perhaps even provider education or health educators. So find your way to the right person in the plans that are going to help you get the job done. And lastly, follow up with praise. You catch more flies with honey than with vinegar. Thank you.
Thank you so much, Meg. That was wonderful. Well, I would like to thank everyone on the call. We have almost 200 people on our webinar today. It's really incredible, and I hope you all can join me in thanking our speakers today. If you've been patiently waiting to ask a question, now's your time. Please see the Manage Q&A box and add your question in there. We have a couple that have come in already that we will go over. But while I give everyone a moment to type in your questions, I'd like to remind you that following this program, an evaluation will be sent to you. We truly appreciate your responses. It is a very short survey, but the information we get from it is very meaningful. The California Immunization Coalition produces at least 3 education hours per year, and we rely on your feedback in preparing and improving these webinars. While people are still, looks like, entering a couple questions in, I would also like to say a huge thank you to Hillary for sharing a story. And the California Immunization Coalition works very closely in order to put faces on vaccine preventable diseases. There is a website called shotbyshot.org that I'll put a plug in for. These are stories of vaccine preventable diseases. And it's a collection of videos and stories and education and awareness resources for patients, colleagues, students, clients, and community. So for any of you that are listening today but maybe don't have a story of your own, these are really powerful ways to share best practices and also why this work is so important. So our first question, it looks like, is for Dr. Royce, and are patients required to receive immunizations in a home or in-network provider, or can they go to any Medi-Cal enrolled provider or pharmacy? Dr. Royce, are you on?
Yes, I am on. I'm not positive about the answer. I suggest you call member services on the back of the person's card to their health plan and ask. It also depends on the MOU that you have, that the health plan has with the county. Some counties are considered in-network and provide services. I think in general, the services need to be provided by an in-network provider. Whether or not that's the assigned medical home, I think you're going to have to talk to the plan. I'm not sure. Is anybody from DHCS on the phone that would like to answer? And then I can also reach out to my colleagues at the State Medicaid Agency after to see if they can answer that question more fully than I can.
Okay. For those of you that are on the webinar, we will be answering the questions that are typed in, and these will be available to you after the webinar as well. Our next question is for Amy. Why was Kaiser not included in the study?
Well, I will be following up to make sure that I give you a thorough answer to this question, but if I recall correctly, I think it's just because for this first year of the study, we wanted to focus on the sites that where the Alliance could have more influence, and also there's not a huge number of Alliance members who are enrolled with Kaiser, so I'll put in writing the real answer to this question, but I think that it just had to do with numbers and where we could get the most benefit in the first year. So we decided to exclude Kaiser.
Great, thank you. Now this is for all of our speakers. We saw some more than others, but in many of the presentations, the utilization of data was a key for improvement. And for those that are on the call that may not necessarily have great access to data or their performance, what do you recommend that people could do to get started?
This is Hillary. I can start. We certainly stratify our, like for example, our members if we're looking at immunization rates and understanding by whatever factors I can get my hands on. So that does include race, ethnicity, spoken language, zip code, primary care provider. I did not share that with you because, today's presentation. That wasn't the point of mine, but I do think it's a really important part of engaging your audience and identifying opportunities.
Great, thank you.
I'll add a little bit to that. This is Sarah Royce from the Immunization Branch at the State Health Department. The Immunization Registry is a source that we encourage all plans to check to see if immunizations are recorded elsewhere. Local health departments have access to that as well. And, of course, we want providers to be using CARE also for the decision support. And so that they can look at the performance, the coverage of their whole patient panel. On the managed care plan side, you'll see in the third bullet of my last slide a link to where you can see the published data from each managed care plan in each county. That's going to give you aggregate data, but then as you've seen, a really nice example both from Alameda and from Central California Alliance for Health, when you sit down with your managed care plan, you can get much more detailed data by zip code, data that's not published, like the prenatal Tdap levels. So getting data from the managed care plans these presentations were really nice illustrations of how that can be really actionable to help focus and evaluate effort.
Great. Thank you, Dr. Royce. Speaking of registries, Sally, you talked a little bit about your use of CARE, and I was wondering if you could tell us a bit more about how you overcame some of the key barriers to supporting that bidirectional load.
It's been interesting to support them. Some providers do have the bidirectional, and some of it they are doing just an upload to use the to use CARE. So not all of our providers yet have bidirectional, but it is increasing significantly.
Great. And Amy, was there anything else that you wanted to add? I know you do a lot of work with CARE, and was there anything else that you'd like to share about the registry?
I don't think so. I will go back to some of the other points. Just that we did the question earlier about breaking down data by race and ethnicity. Just like Dr. Royce said, we've been able to definitely look into that with our project with the Alliance as well. And I also see that a question has been turned in about given the number of challenges that we've had, are there plans to address some of the challenges? Of course, yeah, that's what this project is doing. It's addressing challenges, and that's how our immunization rates, I think, have been able to go up on average about 8%. But yeah, we do look into the registry to see immunization coverage, and it's getting more and more refined all the time, just how to best use the data.
Great, thank you. And I had a question that came in that correlates a little bit with that. And is there a way to get registry data from states outside of California that anyone knows of?
Maybe by sending a data request to the state. I'm not
That's
sure.
correct. If you have a patient, that's correct. If your provider has a patient that got immunized outside the state, our help desk can help them access records from the state that they were immunized in.
Wonderful, thank you.
I would also
Amy,
add I just want to add one more quick thing. This is Sarah Royce again, that adult immunizations are a benefit in the pharmacy. So this relates both to data and to access. So a pregnant woman, if her provider doesn't offer Tdap and flu vaccination, she can go to an in-network provider, an in-network pharmacy, and so I know that, that's a required pharmacy benefit. So that's a little bit about the medical home issue. And then also, pharmacists are the only provider group required by state regulation to report to care. So the data in care for pharmacy-administered immunizations, we think is fairly good. So this would be very helpful for health departments or managed care plans or OBs to check if they're referring women to pharmacies to make sure the women actually got there and got in.
Wonderful, thank you. Amy, another question for you has come in around for pregnant teens, or I guess maybe this is not just for Alameda, so Sarah, you might be able to comment as well, but does pregnant teen who is under 18 years of age require parents' consent to receive Tdap at a pharmacy? One of our OB providers reported that a pharmacy turned a pregnant teen away because she was under 18.
That's really unfortunate that a pharmacy turned a pregnant teen away because she's under 18. I don't know. I feel like there are different. Sarah, do you know the answer to this question?
Yes, under 18 can get certain immunizations without parental consent, like HPV and Hep B, but
right.
Under 18, I don't think even being pregnant obviates the need for parental consent.
It may not be. Sorry, Sarah, this is Sally, and it may not be due to the fact that they were looking at the age as much as the fact that they were VFC eligible.
Yeah, so that's a whole other issue. We got pretty clear guidance, and you'll see that in the FAQs, the pharmacy-administered immunizations, in that second FAQ, that Medi-Cal is currently not authorizing immunization of under 19-year-olds in pharmacies. We are quite worried about pregnant girls accessing Tdap because we know not a lot of OBs. Sometimes they're going to OBs that don't stock, and that's an issue that we're going to try and make a solution to as we understand better how many girls we're talking about, how many young women we're talking about, and I think there are some options with Medi-Cal, at least for that group. We also, I know, have a pilot project that maybe you want to speak to. Hillary, sorry, about other ways to access pharmacy immunization. So this is an active area for us. Can we make some of the pharmacies a VFC provider and then get them the vaccine? So these are kind of cutting edge new things that we're thinking about and starting to work on, and we'll have to report back. Hillary, did you want anything more about making pharmacies a VFC provider?
It's certainly something that we've explored. We're working with our pharmacy benefit manager to look at how we could expand access down to through the teenage years for certain key vaccines for our teens. But it definitely takes a lot of work, and again, you have to negotiate with the Medi-Cal contract requirements and vaccines for children. But it is possible.
Yeah, so as a policy,
I think we're going to, Sarah, maybe we can, if anyone has additional answers, we might be able to type them in and make them available. But at this time, we're approaching the end of our time. And I want to just say that we hope this past hour has provided you with some useful information and inspiring action to help improve partnerships between health plans and public health departments in order to drive higher immunization rates. We'd also like to thank the members of the CIC Education Committee for supporting and planning and coordinating this call. And a very huge thank you to all of you for spending the hour with us. Please remember to complete your evaluation form that will come up after this broadcast and tell us what you thought. In addition, as a reminder, the slides from this webinar as well as past webinars are available on the California Immunization Coalition website that you can find at www.immunizeca.org. You can look under the Resource tab and then the Education Hour. There is also a lot of other information on the site that we think you might be able to utilize or that would be helpful. Please feel free to use. You can also contact us there for any additional information. Thank you so much, and I hope you have a wonderful day today and a very happy holiday.